Good evening, chairpersons, panelists, friends and colleagues. Try to present a couple of calcified undilated lesions where I had some issues in going ahead with the case and finally had a successful outcome. So I had a 17-year-old male who had a history of old inferior wall myocardial infarction and a recent non-ST elevation MI with debilitating angina and a diabetic. He had an angiogram done which showed bad triple vessel disease. RC was a total occlusion and the left side so there's a distal left main lesion, circumflex is badly diseased and LAD is also diseased with calcification. So with this one advised CABG, but he was not willing for CABG, so we had proceeded planned for a multi-vessel PTCA. So try to go for the LAD. So wired the LAD easily, but took 1 mm balloon couple of times. The balloon actually so I took a 1 mm balloon. The 1 mm balloon actually ruptured in the LAD lesion. Multiple times 1 mm balloon was taken. It was not expanding. Then tried for other balloons. None of the balloons was crossing beyond the distal left main. So you can see in that image, in the distal left main, there is a calcific area just beyond the circ, that bifurcation area, which is not allowing any balloon to cross. Then kept the wire like that and then went for the circumflex. Sorry, there's a problem with the slides, so I'm converting from my Mac to the usual VIOS, this thing. Proceed. That's fine.
Some may not work because your file was in chemo. Yeah. We try to convert how much. Some PPT right now.
Yeah, okay, fine.
You can complete. Yeah. Some place it will play automatically. Some place you have to play.
Okay, actually.
Okay. If you move like this, it will come.
Okay, fine, right. So after having failed to dilate the LAD, proceeded with the circ, 2 mm bit disconnected.
Better go to next slide.
Yeah. So tried to dilate the circ. 2 mm balloon was used to dilate the circ, and that was the result after that. But tried to track a stent to the circumflex. No stent was tracking to the circ at all, and a 2 mm balloon dilated the circ, but no further balloons were opening the lesion. So that was the status after more than 2 hours of trying in the cath lab. So this was the point at which I left. So we have a calcified triple vessel disease, an undilatable LAT lesion and an undilatable circ lesion. 1 mm balloon ruptured in the LAD, 1.5 and 2 mm balloons were not crossing beyond the distal left main to LAD. No tracking of stent was happening to the circ lesion. So abandoned basically because 2 hours. Then after having the LAD, went to the circ, needed a microcatheter actually to exchange for the rota wire to go into the circ. Then the circ lesion was burred the same 1.5 bar. So that was a microcatheter exchanging. And I'm sorry, some of the videos are not working because of the interconversion issues. And I took a 1.5, the same burr to the circ to dilate the circ. And I tried to take a long stent to the circ, even with a buddy support. A long stent was not tracking to the circ. So I had to accept a shorter stent for the circ, leaving the ostium and the distal lesion down for a spot stenting of that part alone with a 2.75 into 18 mm drug-eluting stent for the circ. Once the rota was done, all the lesions actually gave way well. I could put a 3 into 18 DUS into the LAD distally. And then left main to the LAD was stented with a 3.5 into 23 drug-eluting stent. And that showed a final good result. So compared with what we had started with rota, I had a good result to the LAD and the circ. So that was the first case. Second case was a 70-year-old male who had a non-ST elevation MI. His angiogram showed a calcified two-vessel disease and he was advised CABG because of calcified lesion, but he opted for a percutaneous intervention. He had a attempt, the RCA was appearing like a straightforward lesion. The distal RCA, but he had an attempt, the angiogram was basically done at a different center and they had attempted a PTCA to RCA first, but they couldn't cross the lesion actually. So they had abandoned and they had suggested a CABG for the patient. Then the angiogram status was a distal RCA lesion and the LAD also had a calcified lesion in the LAD, long lesion. So he had two-vessel disease, LAD and RCA, with a failed attempt to RCA PCA elsewhere. So I started with the LAD. So I took a 1.5 bar to the LAD and it gave way after multiple runs, and then stented the LAD and left main to LAD. Sorry, I have a problem again with the slides. Yeah. And once the LAD was done, I proceeded for the RCA. So RCA on first look was appearing like a easy lesion, distal RCA, but we should note that it was a failed PCA elsewhere, the distal RCA. So because I had notes written the balloon was not dilating, we straight away opted again for an burring to the RCA, and 1.5 mm burr was used at 1,60,000 RPMs to open up the distal lesion in the RCA. So that was a burr going ahead to open the distal RCA lesion. Once the RCA lesion was opened,
hello, hello,
took a non-compliant balloon.
ऑडियो मिल रहा है मेरा?
Was also opening with a waist again there.
कोई बात नहीं,
in the
मेरे को एक ही
rotablated
माइक
part.
वापस टेस्ट नहीं करने, माइक टेस्ट कर लिया, उनको एक बार बस क्वालिटी टेस्ट करा दो, सोर्सेज मांग रहे हैं वो अब चेक करा दो, मैं एक बार फोन को हेडफोन दे रहा हूँ और माइक दे रहा हूँ.
So finally I took a higher
एक
NC
sec.
balloon, opened the distal RCA well, and once that was done, high dilatation was done with an NC balloon.
हेलो 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 हाँ मेरा आवाज़ आ रहा है?
Once that was done, the RCA distal
एकदम
RCA was
clear है
stented
कि-
very well with a good angiographic result.
क्लियर है ना? और वो इको और OCT आ गया क्या? इको आ गया?
So there was a good angiographic result to the distal
वो
RCA.
ठीक है ना?
But the story doesn't end there, because on the table
Check
itself,
कर लिया ना,
after
lock
some
कर
time,
लिया
the
ना?
patient complained of chest pain, and fluoro showed there was a pericardial effusion with
हाँ
clamp.
हाँ 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 वो है ना?
So we aspirated, continued to
वो है
aspirate
कि
and
गए?
autotransfuse.
वो है कि
Even
गए?
after
हाँ
more
दो
than an hour in the cath lab, aspiration, autotransfusing,
हाँ दो ना उनको
he continued to accumulate. Once you aspirate, he settles down, then again accumulates. So finally, more than 2 hours,
हाँ,
we
ऐसे
had
कुछ
to
तो है।
refer him for a thoracotomy. So what had
हाँ।
actually
क्या बोल
happened?
रहे हो?
This was the situation. There was a rent in the right ventricle, not by rota, but by the transvenous temporary pacemaker, which was kept for the procedure. And that was bleeding out torrentially into the cavity. So much so that, see, that was the image, see that hole, that's bleeding torrentially into the RV. We had to put a pledgeted sutures, and the patient had to go for a thoracotomy and closure of the rent in RV, following a temporary pacemaker induced perforation. Anyway, the patient made a good recovery and was discharged.
Hello?
So it was a temporary pacing lead induced perforation following rota, not a
है क्या
rota
वो?
related perforation. That image clearly shows that there is an oozing from the R with a large
अच्छा
rent.
कोई डॉक्टर शर्मा के साथ?
Needed a pledgeted suturing to close off that rent.
किसके साथ थे वो?
The third case I would like to present is an elderly male who came with an acute anterior myocardial infarction. He
डॉक्टर
went into
रविंद्र है
cardiac
कि
shock.
गए?
He was
रविंद्र सिंह
intubated,
राव है कि गए?
ventilated outside, and he was referred in a shock state to our hospital in the middle of the night.
अच्छा अच्छा
So this was the angiogram.
उन्होंने
The
माइक
angiogram
टेस्ट
showed
किया
that
क्या?
He had a left dominant coronary circulation. LAD was totally occluded.
हाँ।
Circumflex had a proximal significant lesion. So that's the
अच्छा।
angiogram again, showing the proximal circumflex lesion and the
करा दिया ना?
total
ठीक है
occlusion.
ठीक है
LAD.
बाकी सब क्लियर है ना? वॉइस मेरा
The
ब्रेक नहीं हो रहा
RCA
ना? रुक रुक के
was
नहीं आ
a
रहा ना? प्रॉपर आ रहा
non-dominant
ना?
vessel which was totally occluded, and it was collateralizing the LAD.
एकदम क्लियर है ना? ओके ठीक है ठीक है चलो तो कल सुबह टेस्टिंग करेंगे आपस की क्या है?
So, progress in a regular fashion, wired to the LAD. Then we took a 1 mm balloon to the LAD. It was
ठीक
very
है।
tight.
ठीक है चलो तो ओके बाय या बाय
But no balloon was actually crossing into the LAD. We thought it's an issue with the guide support, anchored
हाँ जी, तो
another
आप
wire
backup
to the
कर सकते हो,
circ,
आप कर लो
but
अपना।
still no balloon
तो और
beyond a
एक
1
और आपने
mm
check करी
balloon
सुबह आएगा।
cross into the LAD.
हाँ विंडो आप बना लो
It was
और
a jail catheter, a femoral access.
ठीक है
Finally,
सुबह
I
कितने
could
बजे
take a
आप
1
रखो call
mm
time?
balloon, and that dilated the LAD.
हाँ पहले 9
When I had a wire in the circ also for support.
ठीक है
Once
सात
I had
सात
a 1 mm balloon taken across the LAD and dilated, I tried to take further balloons,
सात सात ठीक है ओके
but no other balloon was crossing.
नमस्ते भैया
Then I tried to take a tonus, it was also not crossing. Then I thought it may be a problem with the guide support, changed the JL to an EBU for better guide support. That was also not useful. But then finally, I could track a 1.5 mm balloon, and that dilated partially in the proximal LAD. But beyond that, no other device was tracking into the LAD. And almost after 3 hours and around 400 ml of contrast, this was the situation I was left with for this patient with an anterior wall MI in cardiogenic shock. I'm sorry, again there's a problem with the slides. Sorry for that. So, at that time we didn't have an in-house rota, so no other option. The patient was shifted on ventilator to the intensive care unit, and we had to arrange a rota actually, and 48 hours later we had a rota arranged. We had no other option but to rota him. And when we took him up for an angiogram prior to rota, the vessel had opened, but that tight area which was not allowing a balloon to grow across was still there. So that was the status 48 hours later. Then I took a 1.5 mm bar at 1,70,000 RPMs, crossed the tight area in the LAD, Then once a burr made an easy entry into the LED and opened the lesion, that was the result I got. And once the LED was wired, I wired also the circ. There was a proximal circ lesion. And then the LED and LMCA to LED was also stented, because we seen the images, the ostial LED was also diseased. A problem again with the video, sorry for that. And finally, once the LED and the circ was stented, I had a good acceptable result. And that was a good result after ROTA and PTCA to the LMCA to LED and another stent in the circ. So that was the final result. So that was the final result after ROTA and stenting to the circ and the LED. Thank you.
Thank you very much.
Yeah.
Really very interesting cases, very interesting complication of right ventricle
Perforation.
So it's one of the complications of TAVI.
Yeah.
So it's not so infrequent to have this type of complication. We have to consider its complication. So due to the fact that we are significantly behind the time, we will move to the next presentation. Dr. Samba will
Thank you.
share with us a few cases, few slides that
Your mic
were
is
not
on.
able before due to the live transmission.
Thank you for the second opportunity. Okay. Yeah. As I was showing you, this was a case of NSTEMI, and the angio showed a osteoproximal LAD and a mid-LAD lesion, and we did IVAS for this patient, and IVAS showed a left main disease also. So we had to stent him from the ostial LM to the mid-LAD, and after the stenting, the circumflex ostium was looking very narrowed. So what to do next? We thought of rewiring the LCX and do a kissing balloon inflation, or to assess the LCX with imaging or FFR. We did an imaging with a OCT, and surprisingly the OCT imaging showed a well open circumflex ostium. As we can see, the circumflex ostium was quite open, and we can see this is the LM to the LAD stent, and this is the circumflex ostium. This is the wire in the circumflex. So it was just some sort of, and 3D bifurcation imaging showed a fully opened LCX ostium, and the 3D fly-through imaging also showed a nicely opened LCX ostium. So angiographically, what was looking like a narrowed LCX was basically some sort of spasm or a carinal shift, and we gave some NTG and then corandil, and we took one more shot, and the LCX ostium was looking wide open. So the OCT helped us in avoiding the stent in the circumflex, and it was done with a single stent strategy itself. The another important usefulness of OCT in a bifurcation stenting is the wire crossing. We are supposed to cross the distal strut of the stent across which is placed across the main vessel, so that when we do a kissing balloon to the main vessel, the struts will be covering the ostium of the side branch, and if you do a proximal crossing, then the struts will protrude into the main vessel, which can produce a damage to the main vessel flow. So we are supposed to cross through the distal strut. This is one case where we have done a stenting of the proximal LAD, and the diagonal was pinched. So we wanted to cross the diagonal, and when we crossed and then did a OCT, then we could clearly see that wire had gone through the proximal strut. So if we had done a kissing balloon of this side branch, then all the struts would have been protruding into the main vessel, which may produce future problems. So we again rewired it, and one more OCT run showed nicely showed a distal crossing of the wire through the distal struts. Then we did a kissing balloon, and the circumflex ostium, the diagonal ostium was widely open, and this is another case where there is a LCX OM bifurcation lesion, and we put a wire in both the LCX and the OM, and we couldn't take a balloon to cross that distal LCX lesion and the OM lesion. The balloon was not tracking across the wire. Then we did an OCT imaging, and the OCT imaging showed the wire had gone through the subintima and then entered the side branch. That was the reason the balloon couldn't be tracked over the wire. So this can be seen only by the OCT. The regular angiogram cannot detect this, and if we had tried some other method to cross it, we could have produced some vessel damage, perforation like that. So this abluminal crossing can be seen by the OCT, and this is a very important usefulness of OCT in bifurcation wiring. After that, we removed the wire, recrossed it, and then the post-procedure angiogram was showing a good result. We can see various methods of bifurcation stenting, double stent strategy, and OCT helps in assessing the final results of double stent strategy very well, which is not clearly seen in the angiogram. And this is one case where we have done a QLAT bifurcation stenting, and after the procedure, when we did the OCT imaging, we can see that side branch opening is nicely seen. The stent is covering the ostium, and this is the famous figure of 8 showing both the stents across the ostium of the side branch and the main vessel. This is one more case where we had done a DK crush, and the OCT was showing a glass malapose stent across the at the level of the ostium of the side branch. The malapose stents at the side branch are one reason for future stent restenosis, stent thrombosis in a DK crush. This can be seen only by the OCT, and we corrected this with post dilatation, and the malapposition was corrected. And we have used this biomem branch stent, which was there was a beautiful talk about this, and in one such case, just slash it. Yeah. One such case, we had put a stent, branch stent from LAD to diagonal LAD, proximal LAD, and the side branch. This was the side branch diagonal. And in the angiogram, there was no major dissection seen, but in the OCT, distal to the side branch stent, there was a major dissection which was missed by the angiogram, and OCT helped us in detecting this dissection, and we covered it with the second stent. So OCT is important in getting a good final result in complex PCIs, especially bifurcation PCI, and as of now it is class 2B indication, and over a period of time following ongoing trials results, it will definitely become a class 1 indication. And though there is some cost constraints and there is some learning curve, in India it's picking up, and more and more centers are doing OCT, and definitely it will be useful, especially in bifurcation PCI. Thank you.
Thank you very much.
Thank you, sir.
So, are there any questions or comments from the panel?
My question is to Dr. Praveen, whether he is available like first earlier presentation. In thrombotic lesion, we don't consider rotablation. So what kind of medication he gave before considering rotablation to that patient? Right, next day when he is planning rotablation? So can you elaborate what kind of medicine?
Yes.
So even though it was an acute coronary syndrome, he was not able to cross. So he has to use rotablation to end up the PCI, because he was able to position a glide wire, rotowire, so able to do rotablation to end up this primary PCI procedure. That's what I assumed he used rotablation, because otherwise he could not cross with the small balloon. It's not conventional, I mean, it's not so frequent, but there are some cases even when we have such a calcific lesions, very diffuse lesion, producing STEMI.
Like,
he's here, okay.
I didn't hear the question.
Before you consider that acute MI patient for rotablation in the next morning,
Yeah.
what medication you gave him?
He was only on dual antiplatelets and
Okay.
Only
And
heparin.
heparin,
Yeah.
any GP2B inhibitor?
No,
anything?
GP2 was given at the time of the first procedure. At the
Okay.
time of first procedure.
Okay.
And then he was taken up, actually had a delay of around 48 hours to take up for the next procedure because that time we didn't have an in-house rota. So that time he was only on dual antiplatelets and heparin.
Okay. Thank you.
Yeah, thank you.
Okay, thank you. So next presenter is Dr. Wong from Korea. He will share with us a complex case.
Today's my topic is not unfamiliar to cardiologist. However, I'm cardiologist. My topic is the mesenteric ischemic disease. It's not unfamiliar, it's unfamiliar to cardiologist. However, its causes are very closely related with the coronary cardiac risk factor, and it may be related to the cardiac embolic source, such as atrial fibrillation. And its physiology and the disease behavior is more very likely to myocardial infarction, especially the cardiogenic shock. So it showed a very high mortality, more than 80%. So delayed diagnosis and the treatment of acute mesenteric disease is very catastrophic. So it's the role of cardiologist very important to treat the mesenteric ischemia. Also, RCT data is insufficiency. However, US outcome data show the PTA, early PTA and stent implantation can decrease the in-hospital mortality. According to the improvement in endovascular interventional treatment, in-hospital mortality now are decreasing both in chronic and acute mesenteric ischemic disease. Mesenteric artery anatomy is very likely to coronary artery. It composed of three main branches: celiac trunk, SMA, and IMA. And most important branch to supply to intestine is SMA. SMA ischemia is very important to mesenteric ischemic disease. According to the causes, it can divide into chronic and acute mesenteric ischemic disease. Most important causes are atrial embolization. In almost all cases related with atrial fibrillation. Second most common cause is the atherosclerosis. Almost all cases related with aorta calcification with more than two vessel involvement. Sometimes it can be transferred into acute and chronic stage disease. And the last cause of the SMA ischemia is spontaneous arterial dissection. So today's my case focused mainly on the acute mesenteric ischemia. First case is the atrial embolization case. The 73-year-old male patient developed severe abdominal pain after distal LAD primary PCI. Patient has a history of atrial fibrillation with medication with warfarin. However, patient stopped the warfarin after PCI because we switching to warfarin to dual antiplatelet therapy. This ECG showed the atrial fibrillation with the rapid ventricular response. We emergency checked the CT abdomen. The mid portion of SMA was totally occluded with thrombus. So we performed the emergency angiogram in celiac trunk. There was celiac trunk was patent. However, there was no collateral from celiac trunk to SMA. So we engaged the SMA angiogram SMA mid portion was totally occluded with thrombus, mainly related with atrial fibrillation, and mainly related with the stopping of warfarin. So we infused the intramesenteric urokinase 1 million unit per 60 minutes. However, the thrombus resolution was not incomplete, and the patient also complained of the pain. So we implanted direct stenting, Genesis 6.0 millimeter, using the RGD 7 French guiding catheter, according to the conventional coronary angioplasty technique. It's more like the coronary technique. Put the stent directly. After that, there was no embolization, and the symptom was immediately improved. This is the 3-year follow-up CT finding. The SMA stent was patent, and the patient was well, symptom-free for 3 years. Second case is SMA spontaneous dissection. 75-year female patient admitted to emergency room for abrupt developed squeezing nature abdominal pain. ECG showed sinus ribbon. Abdominal CT showed in mid portion of SMA, mid portion dissected, and we can find intramural thrombosis. In coronal section, the dissection frame arising just below the jejunal branch to distal long dissection. So we performed the emergency angiogram. Celiac trunk were patent, and there was no collateral from celiac trunk to SMA. So we checked the SMA. And the mid portion of SMA was dissected from the arising just below the jejunal branch to the distal portion, long dissection. So we changed the RH5 catheter to RGD 7 French guiding catheter. We performed the procedure according to the conventional coronary angioplasty, primary angioplasty technique. We first performed the thrombectomy and aspiration using the reverse flow thrombectomy suction catheter. At this moment, we also used the axis map for preventing thrombus formation. And we performed the blood angioplasty, nanocross 2.5, 18 millimeter for pre-dilatation. However, distal flow did not recover. However, some part distal SMA slightly visualized after balloon angioplasty. So we decided to implant coronary in DS stent to the mid portion of SMA. You used the Giant's activation 4.0 15 millimeter coronary stent placed to the mid portion of SMA. After stent implantation, distal flow did not improve. However, part distal SMA flow slightly more visualized after first stent implantation. So we decided to put another stent. So we put DS0 3.0 30 millimeter stent to more distal area. After that, the distal SMA flow recovered. We checked the serial DS follow-up for 6 months, 1 month, 3 months, 6 months. Even though we used rather long stent overlapping, there was no restenosis, and distal flow was maintained for 6 months. However, patient complained recurrent abdominal pain, so we performed the elective laparoscope. Very focal portion of small intestine was thickened, and decrease the movement at this point. So we resected that segmental resection. After that, the symptom was improved. So our algorithm to treat the acute mesenteric ischemia is that we perform the ECG and the angiogram first. And if the embolic source was confirmed, the first primary treatment goal is to thrombolysis. And if the primary cause is a dissection, we observe the distal flow. If the distal flow patent and the SMA diameter is more than 6 millimeter, we just observe with the anticoagulation. It's very good prognosis. However, distal flow decrease, we perform the PTA stent primary treatment. If this modality failed, we perform the laparoscopic segmental resection. So PTA being used with increasing frequency of revascularization of acute and chronic mesenteric ischemic disease with low in hospital mortality. However, most important factor influencing outcome in AMI are speed of diagnosis and intervention. Therefore, cardiologists were involved in primary intervention, clinical outcome would be more improved. Thank you.
Thank you very much. Not so convenient field for us, but we are all facing this situation. Are there any questions? Yes, please.
Just one question, please. Regarding what about regarding the lower limbs ischemia, for example? There is an experience from your sides, like acute mesenteric ischemia. Okay, what about the lower limbs? If there is any, like the pulse is not filled bilateral, do we need to do angioplasty also for them, or no need for that? Actually, it's usual scenario with all patients, which is happening after primary PCI, or for example.
Oh.
Yeah, after primary PCI, for example, admission, then after 2 days, 3 days, the nurse will involve you that there is no pulse filled bilateral.
Two point maybe we consider to treat the patient. First is that cause is, what is cause? What is cause of ischemic, mesenteric ischemic disease, acute ischemic mesenteric disease? Which cause? The embolism or dissection? Embolism is a more common cause. It's mainly related with atrial fibrillation. So it's very important to check the ECG before the treatment decision. And that if the cause is related with the thrombus relating with the atrial fibrillation, it's better to treat it using the thrombolytic agent, urokinase. However, its cause is dissection. The treatment strategy is very different to the embolic source. If the dissection, when the dissection was occurred, the SMA diameter is very influenced to the prognosis. The more than 6 millimeter of SMA diameter, when the dissection was occurred, the SMA diameter more than 6 millimeter, the prognosis is very good. So just medical therapy and heparin or warfarin medical treatment is very good prognosis. It's optional. However, less than 6 millimeter and the distal flow decrease is primary PTA or stent implantation is very optional treatment. So we have to classify according to the causes and the diameter. It's very important.
Just more question regarding this one. The cardiologists involved in your country about these cases.
Yes, so because the procedure is a very conventional coronary angioplasty procedure, and it's very likely to the primary PCI in acute myocardial infarction. So it's very important, and the cardiologist very accustomed to team approach. So it's almost all cases in our hospital involved in cardiology in treatment of mesenteric ischemic disease.
Excellent, good.
Yeah.
Nice, thanks.
Thank you very much. The next presenter is Dr. Ravinder. He will present long-term result of long metaphor stent.
everybody. I thank the Meril for bringing me here and share my experience with you. Some 3 years back, I moved from a metro into my second-tier city in southern part of Tamil Nadu, our country. And that's the time I lost the luxury of using the premium long stents in my patients, because most of them used to be poor patients. And by chance, I get to know about this stent, from the Meril, what do you call the metaphor regulating stents. The profile is very much similar to the biomime they claim. The 65 micron cobalt chromium with a hybrid cell design, low injury morphology because of a nice polishing using the laser. As I have just witnessed the manufacturing of the stents in their plant, and it is coated with a biodegradable polymer of less than 2 micron thickness with a 1.25 microgram per millimeter square of sirolimus or eluted over 30 days, and from 2 to 4.5 millimeter diameter they have, and length ranging from 8 to 48. And long stents are available only from 2.5 millimeters. So the advantages and disadvantage of using long stents is that the advantage is that it avoids overlapping of stents, because overlapping is known to produce higher maze than using a longer stents without overlapping, and reduces the stent numbers and hence the cost, and reduces the geographical miss, and reduces the exchanges and the exposure to the radiation. And it also protects side branches, because when we get to overlap the stents at side branches, the chance that for rewiring the side branch becomes lesser and we may lose the side branch. The disadvantages includes that always the length of the disc increases, the long-term maze is higher, but once we decided to stent a patient, it is better to stent with the longer stents than to overlap with 2 stents. And obviously when the stent length increases, the most difficult thing becomes the tracking of the stents through the tortuous vessels or a calcified lesion, etc. And tapering vessels can lead to mismatch, and further the Meril has come up with the tapering stents, though I don't have a personal experience with this. And the inflation deflation times all can cause ischemia, because longer stents needs a longer time of inflation. So an ideal long stent should be having a good procedural outcome in the form of trackability, available in appropriate length and diameter, and should give accessibility to the side branches, should have minimal foreshortening, because foreshortening is a function of the initial length of the stent. The higher the length, the longer you can expect a foreshortening, and also should have a good long-term outcome. I basically wanted to present some complex cases at this meet, but when I searched my data, I found that I have used around 257 metaphor stents in 208 patients in the last 2 years. And when I considered these 37, 40, 44, and 48 millimeter stents as long, I found out that I have used 86 of them in 80 patients, and I am presenting the procedural and the 1-year clinical follow-up. So in RCA, I've used some 43 stents, and out of which 13 were 48 millimeters. All of them tracked easily except for 5, which required, out of which 3 required deep throating, up to the mid-RCA, and 2 required body wise, and no failures were noted in RCA. It includes a CTO lesion like this, which required crossing with hard wires, and tortuous RCAs like this, and osteal lesions. So, and anomalous vessels like this. I didn't use Mac. I don't know why it's not playing. So this is a 48 millimeter stent. You can see that it nicely takes a 360-degree bend of the guide catheter and enters into the RCA so smoothly. And so this is another case where I had to deep throat to reach the lesion segment. And this one where the long stent is tracking with the buddy wire. My God. So that's the RCA, and in the LED I had used 32, of which 17 are 48 millimeters. All of them tracked easily, except for 3. One required buddy wire, and one required an anchor balloon, and one required a guideline after failing both buddy wires, and also one stent got damaged, which I will discuss at the end. So you could see that most of the time we don't store this part of the procedure because it's usually under fluoroscopy. And I just I got lucky that I could show you some of these where the stents nicely tracked, long stents tracked into the LED. So this is one case which was had difficulty in tracking a CTO lesion, and the dual injection shows a total cutoff in the proximal part of the LED with a diffusely diseased vessel down below. So after good predilatation and establishing an antegrade flow, the stent didn't track beyond this mid LED. So in this case, I basically used a guideliner, but what happened is the stent, as it entered through the proximal tip of the guideliner, it got damaged. I couldn't realize that why the stent is not advising, and I later realized that it is not negotiating the proximal edge, because generally we put the guideliner over a balloon, we remove the balloon, and then we take the stent. So while taking the stent through the guideliner, it got stuck in the proximal part and got damaged. So again, I used another stent. So and this time, I made it sure that the stent goes first to the point of the point where it got stuck, and over the stent, I advanced the guideliner further distally, and I could successfully track the stent below. So this is the end result. So regarding the LCX, I believe this is the most difficult vessel to track in anybody's experience. So in this, I used around 7 long stents, and out of which 2 of them are 48 millimeter. 4 of them tracked easily, and the rest other 3 required one required a buddy wire, the other one required a guideliner. And the third one, in a case where both buddy wire and guideliner failed, and I had to use a heart rail. And so technically no stents failure. So it's just a visual to show how these long stents tracks across the LCX. So this vessel, you could see that this long left main followed by almost a S-shaped bend here, and with a critical lesion from proximal, mid, and distal. And in this case, ideally I thought I should use the 2 small stents, but I took a long stent. This is how it behaved. After the point of the mid LCX, it's not taking the curve. So then I anchored a balloon in the mid LCX and tried to track the guideliner, but the guideliner also failed to take the curve. So then I decided to go for a short stent, which also failed. After this one, the short stent, if you notice, it didn't cross even the proximal segment. So basically the problem is with the bend and in the proximal segment of the LCX here. So in this case, then I need to happen to anchor the balloon in the mid LCX, and this time I took a heart rail, which is a 5.5 French system, and the guide is a 7.5 French. I think this is the most yeah, you could see that the guideliner, the heart rail, it smoothly tracks across the curve and goes to the point of the balloon. So next the balloon was deflated, and then the stent could track from this point. So technically this patient had a mid LED and a distal LM lesion, as you could see. So the procedure was completed after deploying the stent and taking care of the LED and also the left main. So regarding the sizes and lengths of this, we have the longer lengths we have is between 37 to 48. We have total 4 sizes, and this is not available in many of these, even the premium stents. And the size, the diameters include from 2.5 to 3.5, 2.5, 3, and 3.5. And these permutations of the diameter and size is much better than other brands. And long stents are prone to have higher force shortening, and here it's less than 0.3%. So it's very useful in ostial position. And regarding the side branch axis, this is one of the most dramatic presentation this patient had. So she was a 65-year-old female with acute pulmonary edema, flash pulmonary edema technically, and ECG showed ST elevation in avia. We know that this patient will be having an left main disease, but not as bad as this is. So the patient was in pulmonary edema, was intubated and reached my hospital around 48 hours after the index event. The patient was in cardiogenic shock. So this is how the lesion. And we stented with a 3.544 millimeter stent from the ostium of the LAD to the distal LAD. And obviously the circumflex flow got reduced, but it was so easy to rewire the circumflex. And once the balloon was opened across the circumflex and the flow was established in circumflex, the hemodynamics dramatically improved. And before completing the procedure, the shock was also, the inotropic requirement came down. So it was a quite good result. Sorry, I don't know why it's not playing here. So in our series of these 80 patients, we had 6 bifurcations were treated, and 4 of them were provisional, and as expected, we ended up with a single stent. We planned for a 2 double stent strategy, and there was no unexpected side branch loss. So the long-term follow-up is what was more exciting for me, because when I followed up these patients, I found that they had a mean follow-up of around 1 year, 361 days exactly. And 3 of them actually stopped the medicines, and I have to restart them after when I collected this data. And 56 of them were diabetics, and 30% of them had a multivessel disease, and 45% of them had an ejection fraction that is less than 45%. And most of the time, 70% of them were treated with aspirin and ticagrelor for 1 month, and then switched to clopidogrel after that. And the remaining 30% were treated with clopidogrel from the beginning. And pre-dilatation with a 1:1 sized balloon was there in 50% of them, and high pressure post-dilatation were done routinely, because these factors are known to affect the pre-dilatation helps in delivering the stents, and the post-dilatation helps in achieving a good long-term result. One patient with cardiogenic shock we lost on the table, which could not be explained by the stent at all, and the rest of them all are doing well. And 15% of them had a repeat angiogram around 6 months for the purpose of different vessel intervention, and the stent was found to be patent without any significant late lumen loss. And 53% of them had completed who had completed 1 year follow-up have a TMT that is negative, and rest of all of them are clinically asymptomatic and they're doing well. There is no stroke or target vessel revascularation or a target lesion revascularation or a non-fatal MI. And the 2 problems I faced with this is that between this rapid exchange port and the proximal shaft, the transition zone, I found it is little weaker at this stent, because the one where I got problem with the guideliner, this transition port got kinked over it, got crumpled upon it as I advanced without noticing the resistance proximally. And the other one, after deploying the stent, when I was trying to pull back the balloon into the guide catheter, I noticed that I'm able to pull out something, but the balloon is not coming out. Then I realized that this part is getting, after that I realized that there is some resistance for the balloon to enter into the guide catheter, so I had to remove en masse into the down, and I noticed that this part of the balloon catheter is elongated, and inadvertently, if not noticed, maybe would have ended up with breaking the balloon within the coronaries. So I want to conclude like this. So the long metaphors that I used in the last 1 year had an excellent procedural and a long-term clinical outcomes. Though it's a single center, single operator retrospective study with only clinical follow-up I have, only in 15% I have a repeat angiogram. the data is reinforcing. And initially, by chance, I started using this stent. By now, I feel by choice, I am started using this stent. And I believe with the Modi Care being launched from this time, stents with good outcomes and which are cheaper would be serving a larger population than the most premium stents. And luckily, we have a stent cap also now. Thank you.
Thank you very much. So we have time for one question or a comment.
Only just it's a nice presentation. Just regarding the long stints, we need actually larger study rather than this. We need larger study to compare between the overlapping stints rather than with the long stint. Another thing also, and it's depend also upon the coronary anatomy also. Like what's the lesion distal to what's the distal lesions, is the diameter of the distal lesions. So a lot of things is there going on. And from our experience in our country, like we have a lot of cases with long stents that have instant restenosis after 6 months. There is studies done in 2004, like one of the there, they saw that there is no difference between both, between overlapping or long stents. Honestly, to me, I prefer to be overlapping rather than long stints from the other retrospective studies. But there is no larger. We need larger study to support this.
Yeah, that's true. Yeah, there are studies to say that the MACE rates are lesser with longer stents compared to overlapping stents. Thank you.
Thank you very much. And now we have the last presentation for today. It's Dr. Singh will present post-CABG intervention and left main intervention.
Hello. Mother? Hello. It's heard? I just want to go to Muhammad wala, next wala. How to go to the first wala? The Muhammad, the first one out of these. Go back. Go back. Muhammad Yunus. Yeah, this one. Okay, so thank you, Chairman and the moderators, Meril. It's quite different than the other topics. So just I don't know how much time I have, but I'll show you 2-3 very good cases of post. Next pictures.
It's not coming clear.
No, I just need pictures. मैं तो ये बोल दूँगा ऐसा. I can go with pictures. Okay, I'll just. Okay, so this patient was around 55-year-old patient with CABG, hypertensive, and again came back after 5 years with chest angina, chest pain. So we did a angiogram. He had a Lima to LED, and he had a SVG to RCA, and then he had a SVG to OM. Now the Lima was all right, but the SVG to OM had a tight lesion in the middle segment, and the RCA, the angiogram is not there. And I think angiogram got the SVG to OM was completely closed. So SVG to RC was completely closed. OM had a tight lesion, and Lima was good. And then we did the normal, actually the native colonies are not there, but I hope they comes. So what we decided, we will open the SVG graft to OM, and then because we tried to open the SVG to RCA, but we couldn't open, so we decided to open a CTO. RCA had a CTO which we thought we'll open, and let's hope it comes. So this is the SVG to OM, and then we took a balloon and opened it. It was quite easy. It opened. See, there was a good flow. So this part was over. So then we decided to now see, this was the SVG to RC was closed. So this is the RCA with the mid proximal lesion, tight lesion, and the mid CTO. So we thought we'd try to open it, and we could open it very nicely. We first took a floppy wire and tried it. It didn't go. Then we took a Whisper MS wire with balloon support, and it went in. And then see, we went in, and then we pre-dilated with different balloons, and finally we exchanged this Whisper with again the floppy wire, and see the floppy wires in, and then we pre-dilated all the because the lesion was from proximal to mid and distal, and we put many stents. We put a 40 by 3 in the distal segment, and then we put a this is distal. Then we put a 3 by we had to take a buddy wire and all this. It was very difficult. It took almost 2.5 hours, and then we took a 3 by 40 in the middle, and then we took another 3.5 by 33, I think, in the proximal segment. See, this is the 3.5 or 33, and then see the result. See, the result was very good. So the policy that if you can't open the SVG and the SVG is closed, better to open the native artery, and which helps, and the patient really became very well, and the angina was not there. And we put 3 stents, but I was just seeing this presentation today, and if I had biomime morph, I think I would have put 2 stents, 50 and 50, and maybe finished it. So this was, it took a lot of time. It looking easy, but it was difficult. Okay, so I have got another very good case. Next. I'll show you this lal fool. Okay.
Screen is not coming proper. Let me just do one settings.
very interesting post CABG, and okay, he you know, CABG and then old anti-wall MI, past 4-5 years CABG, and again came with you know, angina, so we did an angiogram, and then he had a middle lima. He had a lima to LAD and grafts to SVG to OM. So the SVG to OM was patent, but the lima to LAD got mid-segment 100% block. You see, this is a native, the significant native proximal LAD disease, very bad disease, eccentric. Okay. This is the same, again, the native vessel. And this CTO of the RCO, and then there was a SVG graft to RCA, which was also closed. We saw that we couldn't open. So now see the lima. Lima is completely closed here. It's in the middle. It's completely closed. So the option was either to open the lima or maybe open the LAD, native LAD, you know, and it's always better to open the native vessel if you can, and then it was open. It was not 100% closed. We decided to open the LAD. And the OM, it was open. So now we are opening the LAD, we pre-dilate the lesion, and then see, this is the thing after pre-dilatation, and then we took 2 stents, you know, 3 in the distal, and then see the result. So it was actually comparatively easier, you know, instead of trying to go and open a lima, and then it works. So this, and the patient again really did well. He was an old man and he had a pacemaker also, but anyway, okay. Okay, so we have another one patient. I can just take just 1 minute and show. So this one, you know, post CABG, and he developed everything. Left lima was okay, but he developed a SVG to OM, osteal 90% lesion, and when we were trying it, and then we developed a dissection, so we had to put. This is the native LAD. We paged him, and LC was also bad, and this is the RC against CTO, and this is the lima, which is quite good, and this is the RCA, which is you know, again 100% the SVG to RCA, which was also closed. So we thought to open this very tight osteal, you know, SVG lesion to OM. It looked very easy, but when we did it, we developed a dissection, and then we had to put another, you know, another stent. So this is what we dilating, put it, and then we put another stent. And the patient did quite well. Okay, so this was good, and then we decided, we told him to come again for RCA, but he didn't come. Maybe he was good, and then he had a pacemaker also. So this is about the CABG, and if my topic is post left main, left main intervention also. I can show one case if you have time. Can I show now? Not. Okay. Okay. Thank you very much.
Thank you very much for sharing these interesting cases. So we are coming to the end of today's session. we had a really four great live case demonstrations. So we had 2 cases with MERES 100 bioresorbable stent technology, and we had one regular bifurcational PCI case under OCT guidelines, and one fantastic TAVI case with my valve, very good demonstration of a large bore 24 French device with 3 prog lights and a large 29 millimeter of my valve with a perfect outcome. So also we had a very exceptional cases from everyday's complex PCI scenario. So we all appreciate your attendance, your active involvement, and I would like to thank my co-chair panel members and all of you. And we are looking forward for a gala dinner today and half of a day of tomorrow's program. Thank you very much.